major landmarks, and then we will start with the superficial structures which are present in the superficial fascia. Then we'll take out the superficial fascia, we'll go to the deep fascia, talk about the deep fascia of the thigh, and then the muscles of the anterior and the medial compartment of the thigh. So the first objective is to describe the bony landmarks of the hip bone and the femur. If you look at the hip bone, it is basically formed of three bones. The upper 3/5 of this bone is the ilium, then the medial 1/5 is the pubis, and the other 2/5 of this bone is the ischium. All these three bones are united at the acetabulum, which is here, which is articulating with the head of the femur. So these three bones are joining here in the acetabulum to form the hip bone or the innominate bone. Innominate means no name. So sometimes hip bone is also called innominate bone. But it is a combination of three bones: ilium, pubis, and ischium. Okay. So some of the landmarks, if we look at the most prominent one on the ilium is this protrusion, which you can feel on the outer side of your hip, and this is the anterior superior iliac spine. The most prominent thing which you can feel here is the anterior superior iliac spine, and from the anterior superior iliac spine, you have this crest which you see on the top, which is called the iliac crest. This is the iliac crest is going from the anterior superior iliac spine to this point, which is called the posterior superior iliac spine. And there is another spine here below the anterior superior iliac spine, which is called the anterior inferior iliac spine. This area is for articulation with the sacrum. So it's called the sacral tuberosity. And then you have an area which is below this, which is another spine here on the medial aspect. This is the ischial spine. You have the pubis, and the pubis has a superior ramus and it has a inferior ramus. So this is the superior ramus of the pubis, this is the inferior ramus of the pubis. This is the ischial tuberosity, and this is important because this is the place where you sit. When you are sitting, your weight is transmitted through the ischial tuberosity. This area which you see a hollow thing in between the pubic and the ischial bone is called the obturator foramen, and this obturator foramen in adult life is closed by a membrane which is called the obturator membrane. There are certain nerves and vessels which come out from here, which are the obturator nerve and vessels. But you need to know that this is the superior ramus of the pubis, this is the inferior ramus of the pubis. This is also called ischiopubic ramus because it is a joining point between the pubic bone and the ischial bone. So you can also call the inferior ramus as the ischiopubic ramus. Okay, so these are some of the landmarks of the hip bone. Let's look at some of the landmarks of the femur. The first one you would see is the head of the femur, which is here. This is the head of the femur. Then within the head of the femur there is a fossa, or there is a cavity, or there is a depression, and that depression is called the fovea. And this fovea has a ligament attached, and that ligament is called the ligament of head of femur. And you would find an artery going through this ligament, which is called the artery of the head of femur, which supplies the head of femur. Then you can see this constricted area, which is the neck of the femur, and then you can see the two major enlargements here, which is the greater trochanter, and the greater trochanter is similar to the greater tubercle of the humerus. So you can feel the greater trochanter on the side of your hip. This is the greater trochanter on your side of your hip. So greater trochanter is there. This is the anterior aspect of the femur. This is the posterior aspect of the femur. So you can see the greater trochanter here. This is the greater trochanter here. And then similar to the lesser tubercle, you have the lesser trochanter of the femur at a lower part of the neck of the femur. So this is the lesser trochanter, this is the greater trochanter. On the front of the femur, between the greater and the lesser trochanter, there is a line which is called the intertrochanteric line. At the back of the femur, between the greater trochanter and the lesser trochanter, there is a more thick ridge which is called the intertrochanteric crest. Okay? So in front of the femur, between the greater trochanter and lesser trochanter, there is a line. While at the back of the femur, between the greater and the lesser trochanter, there is a thick ridge which is called the intertrochanteric crest. Okay? So it is called intertrochanteric crest. Next, you would see, a tubercle on the intertrochanteric crest, and this tubercle is called the quadrate tubercle. There is also a fossa on the medial aspect of the greater trochanter. This fossa, this is called the intertrochanteric fossa. Then you have these lines on the posterior surface of the shaft of the femur. The medial most line which you see here is the pectineal line, and this pectineal line gives insertion to a muscle which is called the pectineus. That's why it is called pectineal line. Then you would have another line on the lateral aspect, a ridge on the lateral aspect of the superior part of the posterior surface of the shaft of the femur, and this ridge is called the gluteal tuberosity. It's called gluteal tuberosity because it gives insertion to gluteus maximus muscle. Then as you go down, you see this line which is running throughout the shaft of the femur. Can you see this line? It has two lips, one on the medial side, one on the lateral side. And this ridge which you are seeing on the posterior aspect of the shaft of the femur is called linea aspera, and this linea aspera has two lips. One is the medial lip and the other is the lateral lip. So it's running throughout the length of the posterior surface of the shaft of the femur. It has two lips, and these two lips are the medial and lateral lips of linea aspera. If you continue with this linea aspera is going to separate into two lines. Can you see these two lines? Yes. One is called the medial supracondylar ridge, the other is called the lateral supracondylar ridge. Why it is called supracondylar ridge? Because these are the condyles of femur. So this is the medial condyle of the femur, this is the lateral condyle of the femur. So if you see this line, which is just above the medial condyle, is called the medial condylar ridge, supracondylar ridge. The other line is called the lateral supracondylar ridge. So linea aspera, as it goes down, just above the condyles, it is going to separate into medial and the lateral supracondylar ridge. So you have medial and lateral supracondylar ridges. The area between the two medial and lateral supracondylar ridge is called the popliteal fossa. Next, if you see here, we have on the medial side, just on the side of the medial supracondylar ridge is this tubercle, which is called the adductor tubercle. It gives insertion to a muscle which is called adductor magnus. And then you are seeing the patellar fossa in front of the femur, and you are seeing the lateral condyle here and the medial condyle here. And above the condyle there is also the epicondyles, like the epicondyles in the humerus. You have the lateral epicondyle and the medial epicondyle on the medial side. So these are some of the bony landmarks which you should know about the femur as well as the hip bone, because some of the attachment of muscles when we would be talking about, we will talk about pectineal line, gluteal tuberosity, So you should know where these muscles are inserted. Yeah.
Yeah, so what's the nutrition foramen exactly? Is it a whole?
Yeah, it's a nutrient foramen. Through this, a nutrient artery is going to go into the femur to supply the blood supply to the shaft of the femur. Okay. So usually these bones have nutrient foramens which have long shafts and through which the nutrient arteries pass into. Okay. So can somebody read this question for me? You will? Okay, go ahead.
Which of the 11 structures, 1, 2, 3, 4, 5, is trochanteric fossa?
4.
4.
4 is the trochanteric fossa. Okay. And what is 1?
Anterior superior.
Okay. And what is number 2? Obturator foramen. Okay. Number 3? Trochanter. Number 5? Linea aspera. Okay. So these are, as we go on and we finish one objective, we would have certain questions for you just to answer so that we will know, if you are going through the things or not. Okay. Okay, so the second objective which we would have in this session is to describe the cutaneous nerve supply and the lymphatic drainage of the anterior medial aspect of the thigh. Why we are dealing with this? Because once you open up the superficial fascia, you would have superficial structures, which include the sensory nerves, cutaneous nerves, which are supplying the skin. We say cutaneous because they are supplying the skin. And you would have the lymphatic drainage or the superficial lymph nodes, which are draining the lower limb, are also present in the cutaneous or the skin. So once you remove the skin in the superficial fascia, you would find cutaneous nerves, you would find the superficial lymphatics, you would find superficial arteries, and you would find the superficial veins. So these are the 4 structures you would be finding in the superficial fascia. So we would be dealing first with the cutaneous nerves and the lymphatic drainage of which you would see, or the lymphatics which you would see in the cutaneous in the skin. And then we would deal with the cutaneous vessels, and we are going to deal with the superficial veins. And then we will remove the fascia lata, which is the deep fascia, and then we go deep into the anterior aspect of the thigh. Okay? So this objective is to look at the cutaneous nerves and the lymphatic drainage of the anterior medial aspect of the thigh. Okay, so in terms of the cutaneous nerves which supply the anterior medial aspect of the thigh, these cutaneous nerves, or these nerves which are going to supply the skin over the anterior medial aspect of the thigh, they are coming from a plexus which is called the lumbar plexus. And this lumbar plexus is formed in the posterior abdominal wall. So it is not formed in the thigh, it is formed in the posterior abdominal wall from the ventral rami of T12, L1, L2, L3 and L4. So there are, from T12 to L4, there are ventral rami which are going to form the lumbar plexus from T12 to L4, where it is present in the posterior abdominal wall in a muscle which is called the psoas major muscle. This psoas major muscle is present along the lumbar vertebra from L1 to L4, and within the substance of this muscle, these ventral rami of L1, T12 to L1, L2, L3 and L4 are going to join together to form a lumbar plexus. Okay? The lumbar plexus is going to give rise to 6 nerves. It is going to give rise to 6 nerves. The first one is called iliohypogastric. The second one is called iliohypogastric. So ilium and hypogastric region. So the first one is called iliohypogastric. The second one is called ilioinguinal, which is also written here. The third one is called genitofemoral. The fourth one is called the femoral nerve. The fifth nerve is called the obturator nerve, and the sixth one is called the lateral cutaneous nerve of thigh. So there are 6 in total, the nerves which are going to be taken off from the lumbar plexus. The first one is iliohypogastric iliohypogastric. The second one is ilioinguinal. Third one is genitofemoral. Fourth one is femoral nerve. Fifth one is obturator nerve. And the sixth one is lateral cutaneous nerve of thigh. Cutaneous nerve of thigh. Okay? So these are the 6 nerves which are going to come out from the lumbar plexus. Some of them are only cutaneous or sensory, and some of them are mixed nerves. That means they are going to supply the muscles as well as they are going to supply the cutaneous supply. Now most of the anterior medial aspect of the thigh is supplied by these 6 nerves, most of it. I'm not saying all. Iliohypogastric do not supply the thigh. So you remove the iliohypogastric from the 6 lumbar plexus nerves which are going to come out. So the first one which is going to supply the thigh is called the ilioinguinal nerve. It is coming from L1. It supplies the root of the penis. It supplies the anterior 1/3 of the scrotum and the small area of the thigh below the medial end of the inguinal ligament. Inguinal ligament is going to be from the anterior superior iliac spine to the pubic tubercle. So just below the inguinal ligament, you see this purple area. You see this one? This purple area just below the inguinal ligament on the medial aspect of the thigh, just next to the groin. Because the area of the groin, like the root of the penis and the scrotum, is also supplied by ilioinguinal nerve. So this area of the skin is supplied by ilioinguinal nerve. The second one is the femoral branch of the genitofemoral nerve, which is going to supply the skin area over the femoral triangle. It also has a root value of L1. So genitofemoral, the femoral part of the genitofemoral nerve is going to supply the skin area over the femoral triangle. People would ask, what is the femoral triangle? If you flex your thigh, you will feel a depression here on the medial aspect. That is formed by a triangle, which is the femoral triangle. There is a gutter type space here. That's the femoral triangle. So the skin area over the femoral triangle is supplied by the femoral branch of the genitofemoral nerve. The root value of that is also L1. Then this area which you see, the front of the thigh, the front and the medial aspect of the thigh is supplied by these 2 branches, medial femoral cutaneous nerve and intermediate cutaneous nerve of thigh. Both of these are branches of femoral nerve. So ilioinguinal and genitofemoral were direct branches of the lumbar plexus, while medial femoral cutaneous and intermediate cutaneous nerve, these are branches of the femoral nerve. And femoral nerve is the branch of the lumbar plexus. So femoral nerve is cutaneous as well as motor, so it is going to supply the muscles in the front of the thigh also. But it also gives cutaneous branches, and these cutaneous branches are medial femoral cutaneous and intermediate femoral cutaneous, which are going to supply the front of the thigh below the femoral triangle. So below the femoral triangle, the front of the thigh is supplied by medial femoral cutaneous and intermediate femoral cutaneous, which are branches of femoral nerve. Their root value is L2 and L3. Then the lateral aspect of the thigh is supplied by this nerve, which is called the lateral femoral cutaneous nerve of thigh, or the lateral cutaneous nerve of thigh. The importance of this nerve is that this is the only nerve which pierces the inguinal ligament and then enters into the thigh, becoming cutaneous. So sometimes when it passes through the inguinal ligament, it gets compressed within the inguinal ligament. And as a result, people come with the pain on the lateral side of the thigh. And that is called meralgia paresthetica. The condition is called meralgia paresthetica. It happens because the lateral femoral cutaneous nerve of thigh gets compressed within the inguinal ligament as it passes through it. Okay, so it pierces the inguinal ligament just next to the anterior superior iliac spine, and as it passes through it, it gets compressed sometimes and it results in the pain on the lateral side of the thigh. Then we have this nerve, which is the obturator nerve. It supplies the medial aspect of the thigh. Can you see this blue area? This blue area is supplied by the obturator nerve. So the medial side of the thigh is supplied by the obturator nerve. It's a long nerve. Again, it is sensory and motor. So it is going to supply the medial aspect of the thigh, and it is also going to supply some of the muscles in the thigh. It's a long nerve. It is going to pass through the medial part of the psoas major, and then it passes close to the ovarian fossa in the females, and then it enters into the thigh and supplies the medial aspect of the skin of the thigh, and it also supplies some of the muscles which we are going to talk about later. Okay? So these are the 5 nerves which are supplying the skin over the anterior medial aspect of the thigh. And why this is important is because when you are going to confront a patient who comes in and said, okay, I have loss of sensation on the lateral aspect of the thigh. So you need to look at the segments of the spinal cord which are involved, like the lateral femoral cutaneous supplies is coming from L2 and L3. So is there a problem at the L2 or L3 level of the spinal cord, or is there a problem with the nerve which is coming from there and supplying the lateral part of the thigh? So you need to think when somebody comes up with a loss of sensation or pain or whatever. Okay? So that's why it is important to understand the cutaneous distribution or the sensory supply to the skin of different parts of the thigh and the leg and the foot. Okay? Okay, so before we go there, so lateral femoral cutaneous nerve of thigh, as we said before, can get compressed by the inguinal ligament, resulting in altered sensation over the lateral side of the thigh, which is called myalgia prostatica. Okay. Next, we are going to talk about the lymphatic drainage. The superficial lymphatics, which are present in the upper part of the thigh, these are called inguinal lymph nodes. Okay, so you have superficial inguinal lymph nodes and you have deep inguinal lymph nodes. So they are just along the inguinal ligament. You would find superficial inguinal lymph node and deep inguinal lymph node. In the lower limb, the deep lymphatics are going to travel with the deep vessels. Like in the thigh, you have femoral vein. In the back of the knee, you have popliteal vein, and in the leg, you have the anterior and posterior tibial veins. So along these veins, the deep lymphatics are going to travel. Superficial lymphatics are going to go into these superficial inguinal lymph node. And there are 3 parts of these superficial inguinal lymph node. It is basically present in the form of a T. If you see here, there is a group of lymph node here, there is a group of lymph node here, and there is a group of lymph node. There is a group of lymph node here. Can you see that? There are 3 groups of lymph nodes. One is here. These are called the lateral proximal group of lymph node, superficial inguinal lymph node. These are called the medial proximal group of lymph node, or medial superficial inguinal group of lymph node. And this one, which is along the saphenous vein, is called the distal superficial group of inguinal lymph node. So you have lateral, medial, and then you have a vertical one which is called the distal superficial group of lymph node. This group of lymph node is draining the buttock, flank, and back below the waist. So it is basically draining the buttock, the flank, and the waist, the skin over the waist below the waistline. You know, this skin at the back below the waistline, buttock, and the flank is drained by the lateral proximal group of lymph nodes. While the medial proximal group of lymph nodes of superficial inguinal lymph node, they are going to drain the skin over the anterior abdominal wall from the umbilicus to the inguinal ligament. So this all area from the umbilicus below the anterior abdominal wall is drained into the medial superficial inguinal lymph node. Plus, it is going to drain the skin over the external genitalia in both sexes, and it is also going to drain the area of the lower part of the anal canal, and it is also going to drain the area of the uterus. So if you have any infection, abscess or anything in this area, the lymph nodes which are going to get enlarged are the medial superficial inguinal lymph node. The distal group which you see here, which is this one, is going to drain all of the skin of the lower limb except the posterior lateral calf. So the posterior lateral calf, except this posterior lateral calf, all of the skin of the lower limb is going to drain into the distal group of the superficial inguinal lymph node. So the question is, where is the posterior lateral calf is going to drain? That is going to drain into the deep inguinal group of lymph nodes, which is traveling with the deep vessels. Okay, so the lymphatics of the deep from the deep part are traveling with the deep vessels. So the posterior lateral calf is going to drain into the deep inguinal lymph nodes. But the rest of the lower limb, the skin over the lower limb, is going to go to the distal group. The medial group is mainly responsible for the skin below the umbilicus on the anterior abdominal wall, the external genitalia, the anal canal, and the uterus. This is again showing you the dark green thing is the deep lymphatics, and the light green one are the superficial lymphatics. Both deep inguinal group of lymph nodes and the superficial inguinal group of lymph nodes are going to drain ultimately to the external iliac group of lymph nodes. Okay, can somebody read this question for me? You at the back.
Okay, a patient came with an abscess in the skin on the medial aspect of the thigh, just above the knee. On examination, a physician will find which one of the following group of lymph nodes enlarged: A. Proximal lateral group of superficial inguinal lymph nodes. B. Proximal medial group of superficial inguinal lymph nodes. C. Distal group of superficial inguinal lymph nodes. D. Deep inguinal lymph nodes. And E. Internal iliac group of lymph nodes. And C.
It's C.
Yeah.
Okay. Can you give me an example of when A would be correct?
A would be correct. Inflammation somewhere in the lower abdominal wall.
Buttocks, back, or flank. Okay. Can somebody give me an example for the B to be correct? Yes.
Anal canal, uterus,
Okay.
umbilicus.
Umbilicus.
Below the umbilicus.
Below the
All
umbilicus.
these
Okay.
superficial genitalia.
Anybody can give me an example for the deep inguinal lymph nodes? When the deep inguinal posterior lateral part of the calf, if there is an infection there, that would go into deep inguinal group of lymph nodes. Okay, the next one. Who's going to read that? Somebody from here. Can you read it for me?
A 30-year-old woman came with pain on the medial aspect of the right thigh, just above the knee. Abdominal MRI revealed an ovarian cyst compressing the nerve. Which of the following nerve is compressed in this case?
Yes. Medial aspect. Yeah. So which nerves supply on the medial aspect of the thigh?
E.
Can somebody tell me which nerves supply on the medial aspect of the thigh? Yes. Obturator. Yes.
Medial cutaneous,
Medial cutaneous nerve of thigh.
genitofemoral.
Genitofemoral. It's basically the femoral triangle, not the medial aspect of the thigh.
Is it A? Because it might get
Lateral cutaneous nerve is supplying the lateral side of the thigh. We are talking about the medial aspect of the thigh. Okay. So it could be either obturator or the medial cutaneous nerve of thigh. And we said that the medial cutaneous nerve of thigh is a branch of the femoral nerve. So it is going to come out when it is going to be, the nerve is in the thigh, because it is coming out from the femoral nerve. But we are also telling you here that there is an ovarian cyst which is compressing the nerve. An ovarian cyst would be, the ovaries are where? In the pelvis. They are not basically present in the thigh. So anything which is coming up from above could be compressed, and that could be the only nerve which can be compressed here is the obturator, because it is supplying on the medial side. And obturator nerve, you should remember that when it is passing through the pelvis, it passes very close to the ovarian fossa, where the ovaries are located. So if there is a tumor of the ovaries or there is a cyst of the ovaries, it is going to compress the nerve, and as a result you might have the pain on the medial side of the thigh. Yes, go ahead.
But the question says above the knee.
Yes, above the knee, on the medial side of the thigh. If we go back and you see this,
I can see.
you see this one?
Yes.
This is the knee. Above the knee, on the medial side of the thigh, this nerve is supplying, which is the obturator. Okay? Okay. So now we are going to come to the superficial arteries and the superficial veins. So we are going to discuss the superficial arteries and the superficial veins which are supplying the anterior medial aspect of the thigh. So the superficial arteries first, and if we look here, the first artery which you are seeing here is this big artery, which is basically the continuation of the external iliac artery below the inguinal ligament. And this artery is called the femoral artery. Or sometimes people would refer it, on some books you would find it is called superficial femoral artery. The reason why it is called superficial femoral artery,
Because there is another deep one.
yeah, there is a deep artery also, and then there is, it's basically quite superficial here, just below the inguinal ligament. So it is lying midway between the anterior superior iliac spine and the pubic tubercle. So between the anterior superior iliac spine and pubic tubercle, if you go midway, you can pulsate this artery along the head of the femur. If you compress this artery along the head of the femur, midway between the pubic tubercle and the anterior iliac spine. So this is lying basically So if you see here, this is basically lying between the anterior superior iliac spine and the pubic tubercle. So this is lying midway. It's called the mid-inguinal point. So this is the area where you can pulsate the femoral artery along the head of the femur. So it's quite superficial here. This is the artery which is also used for taking the arterial blood. You take arterial blood from the radial artery for doing the arterial blood gas. Similarly, you can also use the femoral artery just below the inguinal ligament, midway between the anterior superior iliac spine and the pubic tubercle at the mid-inguinal point, to take the blood for arterial blood gas. The only problem here is that the femoral vein is quite close by here also. So sometimes you are taking the arterial blood, you might take the venous blood. Okay? So you need to be careful. When you put up the needle in, you need to see the plunger is going up, because the artery should have pressure.
Yeah.
So if it is not, plunger is not coming up, this means that you are basically in the vein, not in the artery. But artery is more superficial here than the vein. That's why you can take the arterial blood from the femoral artery here. The other importance for the femoral artery here is that you can do, you can pass an arterial catheterization. You can do it from the femoral artery here because it is quite superficial here. So you can put a catheter into the artery and then you can inject the dye, so those type of things can be done. Arterial catheterization can be done here through the femoral artery because it is quite superficial here. It is going to give 4 superficial branches. One is called the superficial circumflex artery, which is going from the femoral towards this anterior superior iliac spine. The other is called the superficial epigastric, which is coming from the femoral artery, going towards the umbilicus. The third one is called the superficial external pudendal, which is coming from the femoral and going towards the groin. And the other one, the fourth one, is called deep external pudendal, that is also going towards the groin. So these are the four superficial branches of the femoral artery. Now, this is a femoral triangle. Can you make out this gutter type shaped thing?
Yes.
Yeah? This is a femoral triangle. So these four superficial branches are given in the femoral triangle. And then it gives another big artery, which is this one. Can you say this one?
Yes. Yes.
This artery is the profunda femoris artery, or sometimes it is called the deep femoral artery. What you need to realize is that the femoral artery itself is not, the superficial femoral artery itself does not give deep branches to the thigh. So the deep branches to the muscles and other components are going to come from the profunda femoris, which is the branch or the deep femoral artery, which is a branch of the femoral artery. What it would do is that this, after giving these four superficial branches and this deep branch, it will pass through the thigh and pass to the back of the knee, becoming the popliteal artery, and then go into the leg, becoming anterior and posterior tibial artery. So it is mainly supplying deep branches to the leg and the foot. The superficial femoral artery itself is not giving any deep branch except the profunda. It's not going to give any deep branch into the thigh. So if I tie up the femoral artery after it has given up the profunda, there would be no blood loss, there would be no ischemia of the thigh, but there would be ischemia of the leg and the foot. Do you understand what I'm saying?
Yeah.
What I'm saying is that the major artery of the thigh is profunda femoris, which is the deep femoral artery. So if you are going to tie up the femoral artery after it has given the profunda, it is going to result in ischemia of the leg and the foot, but the thigh would still be all right because it is supplied by profunda itself. You understand what I'm saying? Everybody?
Yes.
And it's an important concept. You need to understand that the femoral artery, the superficial femoral artery, is going to give four superficial branches, and then it is going to give profunda. And the profunda itself is the one which is the major blood supply to the thigh. Then it is going to, femoral artery is going to continue to the back of the knee, becoming the popliteal artery. Popliteal artery will divide into anterior and posterior tibial arteries, which supply the leg and then the foot. So if you tie up the femoral artery after it has given the profunda, the blood supply of the thigh will remain intact because major blood supply of the thigh is coming from profunda. But there would be ischemia of the leg and the foot.
By
Okay.
ischemia, you mean necrosis?
Ischemia means decreased blood supply or decreased oxygenation. These are muscles. Muscles
Yeah.
need oxygen.
Good.
And if you do not give them blood, there would be ischemia or less oxygen to these muscles. Okay? Ischemia will lead to necrosis. Because if ischemia remains for a long time, then it will result in death of the tissue, which is the necrosis. Okay, next we are going to talk about the veins. So the first type of veins which we are going to talk about are the superficial veins. And like in the upper limb, you have the cephalic vein and the basalic vein. You have in the lower limb the superficial veins, which are the great saphenous and the small saphenous. So you have a great saphenous vein and you have a small saphenous vein. If you remember your venous drainage in the upper limb, you have a dorsal venous arch on the dorsum of the hand. Similarly, you have a dorsal venous arch on the foot. So on the foot you have a dorsal venous arch. The dorsal venous arch on the foot would have a medial end and it would have a lateral end. So from the medial end of the dorsal venous arch in the foot, this is the dorsal venous arch in the foot. The medial end of the dorsal venous arch is going to give rise to this long vein, which is called the great saphenous vein. This great saphenous vein is going to pass in front of the medial malleolus. As it is going to go up, it is going to pass in front of the medial malleolus. So it is passing just in front of the medial malleolus. What is medial malleolus? This
The bone
elevation
landmark.
which you have on the medial side of the ankle, this is called medial malleolus. So it is going to pass in front of the medial malleolus, pass on the medial aspect of the leg. Around the knee, it is about a hand's breadth behind the medial aspect of the knee. So in the knee region, if you want to find the saphenous vein, it would be one hand's breadth behind the knee on the medial aspect. Then it will continue on the medial aspect of the thigh and pass through an opening in the fascia lata, which is the deep fascia of the thigh, to enter into the femoral vein. So the course of the great saphenous vein is that it starts from the medial end of the dorsal venous arch. It passes in front of the medial malleolus, and then it passes over the medial aspect of the leg. At the knee joint, it is about a hand's breadth behind the knee joint or the medial aspect. Then it comes in front, it spirals in front on the medial aspect of the thigh, and then it passes through an opening in the fascia lata or the deep fascia to enter into the femoral vein. Okay. Now the importance of the superficial veins, and the other one, the second vein, which is the superficial vein, is the small saphenous. So it is going to start from the lateral end of the dorsal venous arch, and it will pass behind the lateral malleolus. So rather than medial malleolus, it is going to pass behind the lateral malleolus, run over the posterior aspect of the leg, and enter into the popliteal vein. So in the leg, it is going to finish the small saphenous. It starts from the lateral end of the dorsal venous arch, passes behind the lateral malleolus, runs over the posterior aspect of the leg, and enters into the popliteal vein. Now you need to understand that these are superficial veins. There are deep veins also. Deep veins are basically following what? They are following the arteries. So you would have a femoral vein, you would have a popliteal vein, you would have an anterior tibial vein and a posterior tibial vein. The deep veins are high pressure veins because they are along the artery. Artery is pulsatile, and the deep veins have more pressure than the superficial veins. The blood normally in the lower limb is moving from the superficial veins to deep veins. Okay, so it is moving from the communications between great saphenous and small saphenous with the deep veins. So it is passing from superficial to deep veins. And these communicators between the superficial veins and the deep veins have valves, so that the blood from the high pressure veins cannot go back to the superficial veins. But if these valves become incompetent, for example, in people, you have seen these guards in front of the palace of the Queen in the UK, they keep on standing in one position. So if you are standing for a long time in a still position, what would happen is that these valves will become incompetent. And if these valves between the superficial veins and the deep veins will become incompetent, the blood will be moving from the high pressure veins to superficial veins. So as it will go into the superficial vein, it will start to accumulate there. So it will form bag-like swellings, like worms. You would see like bag-like swelling blue things, which are like a bunch of worms. And these are called varicose veins. So varicose veins develop because the valves between the superficial veins and the deep veins become incompetent. And as a result, the blood will start to move from high pressure to low pressure veins, and they will form bulgings of these veins, and it looks like a bag of worms. So one of the clinical importance of these superficial veins is that you need to see that if the valves between the superficial and deep veins will become incompetent, it will result into varicose veins. The other clinical importance, yes.
Continue, because I wanted to ask about it.
You can ask me, just let me finish this. So the second clinical importance of the superficial veins, especially for the great saphenous vein, is sometimes you would get patients which have very low blood pressure, okay, or they have lost a lot of blood and their blood pressure has gone down. So if you look at their superficial veins, they are all collapsed. So you cannot put up a cannula and start putting up the fluid in. So because we know that the great saphenous vein in front of the medial malleolus is very superficial. So what you can do is make a cut in the skin, expose the great saphenous vein, and put the cannula in and start pumping the blood. So this procedure is called the venous cut down procedure, and it is done just in front of the medial malleolus because we know the location of the great saphenous vein. Here there is nothing else except the great saphenous. You open up the skin, identify the great saphenous, put up the cannula and start putting up the fluid. So in patients with low blood pressure or with collapsed veins, and if you want to push fluid, one of the easiest site to put up the cannula is to find out the great saphenous in front of the medial malleolus, expose it, and then put up the cannula in and start doing. This procedure is called the venous cut down procedure. So you have only one, if you get a patient like this, you have only two choices. Either do put a subclavian catheter in blindly, or you do a venous cut down and start putting the fluid through the saphenous vein. The third clinical importance of the saphenous vein is that sometimes it is used for doing the cardiac bypass surgery. What is a cardiac bypass surgery? Somebody knows about that? Yeah, somebody at the back. Yeah, what is a cardiac bypass surgery? You were holding your hand. Okay. You were telling me something. Yeah, cardiac bypass. What is it?
Cardiac bypass is when there is a clotting preventing the arterial supply for the heart itself. Then they'll get like this vein apart from this vein to bypass
the blockage.
clot.
Yeah.
Yes.
So there are
they
three
want-
major arteries which are supplying the heart muscles: the right coronary, left coronary, and the left anterior descending artery. If there is a blockage in this artery, you need to bypass it. So you take out this vessel and then you join it, to bypass the blockage in these vein arteries. This is called the cardiac bypass procedure. So sometimes the saphenous vein is also used for cardiac bypass surgery. Either this or the internal memory artery or internal thoracic artery is used for this purpose, for cardiac bypass surgery. So either you use great saphenous vein or you use the internal thoracic artery for doing the cardiac bypass in that procedure. Yes, go
They
ahead.
always use it from the same person. They can't get it from another one.
If you get it from the other person, there would be immune reaction.
Yes.
So it's not self. So you cannot take the tissues from the other person.
As they transport kidneys and so.
Yes. When you do that, put the kidneys, you give immunosuppressant drugs to them. So you don't need that. When you have the saphenous vein from yourself, why do you need somebody else's
It
saphenous
doesn't
vein?
affect the body.
No, it doesn't affect, because you have the deep veins. The superficial veins are there, which are accessory veins, but you don't need them, for all the purpose, because you still have deep veins.
But they are flexible. I heard they can be fixed together back
Yes.
after cutting some.
Yeah. Okay. Next we have a question for you. Somebody from the back. Can you read the question for me, please? Yes.
A patient was received in the ER in a hypovolemic shock with the collapsed superficial veins. A resident tried to perform a vein cut down procedure. He will locate great saphenous vein. A in front the lateral lobus, B behind the medial malleolus, C behind the medial aspect of the knee, D behind the lateral aspect of the knee, E in front of the medial malleolus.
Yes. Yes. In front of the medial malleolus. The C is also right behind the medial aspect of the knee, but that is quite deep, so it's not easy to find out the great saphenous vein there. So the most easily accessible site is the in front of the medial malleolus, where it is very superficial and you would not damage anything else. Okay, so we have a 5-minute break, and then we will do with the objectives 4 to 8.
No, not the
Okay.